25th of this month, March, is Diabetes Alert Day. It's an opportunity set aside by the American Diabetes Association that highlights the seriousness of diabetes and the importance of management. To learn more about diabetes and the impacts it can have on folks with it, their support systems, and their caregivers, I spoke with Dr. Mary DeGroot, a professor of medicine at the Indiana University School of Medicine. She's a clinical health psychologist whose research focuses on examining the mechanisms that link diabetes and depression. For Mary, understanding the psychological burden that diabetes places on people is more than just a job. It's a calling.
My passion is the development of community-based interventions to address the psychosocial issues related to diabetes. So I have done work in the area of depression and diabetes, as well as the work that I'll be happy to talk about today, which is related to diabetes distress and that experience in adults with type 1 and type 2 diabetes.
My first question was a simple one. What are diabetes prevalence rates like right now?
Unfortunately, prevalence rates continue to rise. We are now exceeding 40.1 million people in the US with diagnosed and undiagnosed type 1 or type 2 diabetes, which constitutes about 12% of the US population. And 115 million people have prediabetes, which means that they do not yet meet full diagnostic criteria for type 1 or type 2 diabetes, but they are in the queue. And so that's a tremendous number of people across the country. When we think about areas of the country, whether we think about metropolitan or non-metropolitan areas, we know that the burdens are higher in rural and non-metropolitan areas. About 10% of people in rural or non-metropolitan areas have diagnosed type 2 diabetes, predominantly type 2 diabetes, but there could also be type 1 diabetes. Here in Indiana, our rates are at 11.5% of people in our communities have diagnosed diabetes. But of course, the burden of prediabetes is even higher than that. So this is a very serious set of conditions that is all too prevalent in our communities.
Wow, I knew it was prevalent, but I didn't realize the numbers were quite that high. And is that something where it's just been continuing to increase?
It has, unfortunately. And there's a number of factors that are drivers for that, and one of which is longevity. So, people with diabetes, the good news about diabetes, if we can say that there is some, and we can, is that people with diabetes are living longer than any other time in the history of diabetes, going back to the ancient Greeks who named the term in the first place. We have more medications, we have more behavioral tools, we have more devices than we've ever had to help people support their health and manage their blood sugars in a way that helps them live and thrive with their diabetes for longer periods of time. That also has some consequences, and one of those is that there's more for people to do than there's ever been, and so that helps to set the stage for diabetes distress, unfortunately.
So, diabetes distress, I know a lot of the work that you do is centered around that. Can you tell me more about what that is?
So, diabetes distress is a term that was coined by Dr. William Polanski and Dr. Larry Fisher back in the late 1980s, early 1990s, that relates to the emotional stress of caring for diabetes. And that has a number of different domains. So, it's not just kind of one thing. That can involve struggles with self care routines, struggles with one's healthcare team, or the barriers that get in the way of obtaining healthcare or medications or devices, limited sources of social support, feelings of failure or disappointment with individual blood sugars or A1C values, which of course is the average measure of blood sugars over a 3-month period. That could involve feelings of depression, depressed mood, or anxiety, as well as feelings of powerlessness. This is unlike depression, which can be a more global experience. Diabetes distress is really directly related to the experience of living with diabetes 24/7, 365. And what we know is that diabetes, distress, and depression present differently. They can present together, so they're not mutually exclusive, but we do think of them as separate components. We also use the word diabetes burnout, and that tends to be the behavioral manifestation of that distress. So, distress tends to be the internal experience, burnout tends to be what we see in the clinical environment. So, as a clinical health psychologist, I see patients here in Indianapolis, and so typical presentations of burnout are loss of motivation for self-care behaviors, an inability to maintain one's regimen, that 24/7, 365 cadence that we ask patients to do. That can be, again, lack of confidence in being able to manage blood sugars, and repeated disappointments, and elevated A1Cs.
Something I wanted to know more about was the stigma that surrounds diabetes, and how is the impact of that stigma felt by those with diabetes?
So we have more understanding now of stigma, both for overweight and for diabetes, than we have understood in the past. In the past, there has been a tendency to think about trying to support people, and I put that in air quotes, through moral judgment. So a moral lens is kind of our go-to. That's our default setting, we come by it honestly because it's hardwired in our brains in the amygdala, which is the emotion center of the brain. But what we know empirically is that when people feel judged, when they feel criticized, when they are told that they're not doing well and that that's personalized, whether that comes from the outside, from a healthcare provider or a well-meaning family friend or a family member, however that comes, when that gets internalized, right, it ends up having the opposite of the effect that was desired, right? Instead of supporting people, instead of helping them form the path of self-care that we know can lead to better outcomes, it actually has the reverse effect and actually makes it harder for people to engage in that self-care and contributes to a downward cycle of distress and burnout. So, the stigma has been a huge topic. There is an international effort to end diabetes stigma. I've been very honored and pleased to be part of a 51-member international consensus statement that was published last year, designed to end diabetes stigma, and is something that we can all contribute to, and certainly contributes to the experience of diabetes distress.
No, that's so good to hear, though, that there are steps being taken because I've had diabetes in my own family, and there's a lot of moralizing that goes on around it. The same sort of language you get around like substance use disorder and that kind of thing, just a lot of moral judgment there. So I'm glad that's something that's being considered as we're talking about how to deal with this diabetes burnout, this diabetes distress.
Yes, yes. And we can all contribute to reversing that trend, right? So that's the good news about stigma is that we can decide not to use some of those terms that tend to. The phrase I like to use is little paper cuts to the soul, including some of the terms that we use clinically, we don't even realize have some of that negative effect. So even the word control, so we've used the word blood sugar control, we use that a lot in the world of diabetes, but that ends up kind of suggesting to people with diabetes as though they can think their way out of a high or a low blood sugar. And while we want people thinking about management, it's not something that we can just force ourselves to have a blood sugar within our target range. We can't just kind of imagine, okay, that's the number I want, and that it happens on our meter, right, or on our device. So when we use that kind of language, that really suggests it's very suggestive to people that it should work that way, when in fact it doesn't. So when we are mindful of the terms that we use, if we use the word management, if we use the word guide, if we use the words influence our blood sugars, it's first of all more accurate, and also more helpful and less judgy for our patients. So.
The impact of a diabetes diagnosis can be far reaching. I was surprised to hear that diabetes distress and burnout isn't limited to the patients themselves.
Diabetes distress and burnout is not limited to people with diabetes, although it certainly is experienced by a pretty high rate of people with diabetes, type 1 and type 2 diabetes. Yeah, anywhere between 18 to 45% of people with diabetes will be experiencing diabetes distress at some level at any given time. And that's an extraordinary number, right? It's just huge. But diabetes distress is not limited to the person with diabetes. So it affects children, it affects adults, it affects parents, it can affect spouses, and it can affect healthcare providers. And we have measures for all of those different categories of people. So if someone who's listening is interested in capturing, well, what is the level of diabetes distress that someone in our environment or what some category of people in our environment are experiencing, we have measures for all of those categories, including healthcare providers. So really important that if that's already in the air, we can identify that, and then once we identify it, we can take some steps to help to alleviate it.
So, what's the larger impact of diabetes distress? According to Mary and the work she's done, it can be extensive and far reaching.
But there's good reasons for us to care about diabetes distress. We know that diabetes distress has linear relationship to A1C. So the higher the distress, the higher the A1C. And that has a closer relationship than depressed mood has to A1C. So depressed mood tends to have some intervening variables between those two variables, depression and A1C, but diabetes distress is direct. We also know that diabetes distress is not just a bad day with one's blood sugars, right? It tends to be a persistent experience and can last upwards to 9 months. And so that's a long time to feel badly about oneself, to feel badly or frustrated with blood sugar management. Really important that we can help to identify that and then take steps to address it.
Let's talk about the steps. Like, how do we reduce diabetes distress?
Good news is there's a number of different ways to get there. Um, yeah, good news. So one of the early studies on diabetes distress addressed education. And so, if you're a provider and you have access to a diabetes education or a diabetes care center, that is a great way to connect your patient to specialty knowledge, right, and interventions that can help to alleviate some of those frustrations in managing diabetes. Myth busting is very important. That many of our patients have many different theories of health. Some of those correspond with our own theories of health that are based on the science of medicine, but other theories don't. And so it's really important that we share each other's theories and help to build some bridges to be on the same page between providers and patients. Problem solving is another empirically validated way of addressing some of those pebbles in our shoes, if you will, those difficulties that come up time and time and time again. But I don't really necessarily have strategies to address that, right? So that's where problem solving is helpful for patients. Um, there's also an emotional component to distress, right? So it's in the word distress. That's emotional. That's where my work has focused is how can we bring the education components and the emotional components of diabetes distress together and then address those simultaneously. And that's the work that I've done in the what we call the diabetes tune-up group studies.
So tell me about those, the tune-up group interventions. Like, what do those look like? What are those?
So has been designed as a 6-session series of discussion groups that are co-facilitated by a diabetes care and education specialist. So that could be a diabetes education nurse, or it could be a dietitian, um, and partnered with a behavioral health specialist. And the idea here is that each bring unique expertise to understanding diabetes, and when combined, really speak to the whole experience of diabetes distress. Rather than just one side of the equation, if you will, or the other, one side of the coin or the other. And so, in this series of groups, this is an empirically validated intervention, meaning that we have a manual, we have handouts for our participants who have participated in the group. And we cover a variety of different topics. The first, one of the most active ingredients in the diabetes tune-up group is others. So many people with diabetes can feel pretty alone with their diabetes. Even if there are other members of their family or people they know have diabetes, they may not feel that their experience is really seen or felt, and it can feel pretty invisible and pretty lonely. So when we pull together a group of people who have something in common, like the same type of diabetes, type 1 or type 2 diabetes, who are experiencing distress, that in and of itself is a really important and can be very powerful experience. We cover a variety of topics across the 6 sessions. We first define what diabetes distress is. I've had more patients than I can count now who tell me, I didn't even know that was a thing. I didn't know that that was real. I just thought there was something about me that wasn't living up to the standards that I was supposed to be keeping. And that's that that must it was an internal experience only. So we talk about that. We talk about motivational interviewing and the stages of change. So where are people in their journey with their diabetes, and how comfortable are they with taking on different tasks? In diabetes, it's a target-rich environment. So we have many different strategies we want people to employ. We have many different behaviors we want people to engage in. We're not ready to do all of those at the same time. And so we help people to identify where are they not really ready to engage, and what are the areas that they're already engaging in across that continuum. We talk about social support. We talk about miscarried helping. So sometimes that's termed the diabetes police, those very well-meaning, well-intentioned people in our lives who want the very best for us, but don't necessarily know how to go about giving us what we really need. And we talk about communication strategies with those folks. We talk about communication strategies with healthcare providers. How can we get the most out of our appointments while still respecting the boundaries of those appointments, the amount of time that we have with our provider at any given time? And then we talk about behavioral adherence. What are some of the tools that can help to support consistent engagement with diabetes self-care? And we talk about nutrition. And all of these pieces are interwoven into all of these pieces, I should say, are diabetes education topics that group members select at the beginning. So this is tailored to what their needs are. And as you can imagine, food comes up very often as part of as part of those topics. Yeah.
I wanted to know more about the potential for virtual care. These programs sound incredibly useful for folks that can access them, but can telehealth be used to increase reach? And if it can, are these programs still just as effective?
So one of the things that I've very dedicated to is creating clinical interventions that not only sound and feel like a good idea, but that have data behind them. And so I've conducted 2 different funded studies to evaluate the diabetes tune-up group experience, with our primary outcomes being diabetes distress. So can we reduce diabetes distress from baseline to post-intervention? And then also, can we influence A1C? Because A1C is the name of the game when it comes to diabetes. And so across the first study that I conducted with my colleagues here at IU, we offered the diabetes tune-up group 2 separate groups of adults with type 1 diabetes and separate groups with adults with type 2 diabetes. So, and that was very important because we want people to have others in the group that share a common experience. And of course, type 1 and type 2 diabetes are very different kinds of journeys. So that was important. And what we found, looking from baseline to post-intervention and 3-month follow-up, was that we saw significant improvements in both diabetes distress and A1C in both our type 1 and our type 2 groups. So we were very, very pleased by that. That study took place in 2018, so that was before the big pivot, as I like to call it, where we introduced virtual care in a big way, as because we needed to during the height of the COVID-19 pandemic. One of the unintended consequences of the pandemic was that we do have this capacity now, and there was this huge learning curve that we all went through. As a clinician, I went through this, in my setting. All of our patients did, our staff members did, everyone kind of learned to use tools like Zoom, like Teams, and other kinds of online platforms that allow us to have video calls with pretty good technology support. And so, in our second study, what we wanted to do that was funded by the American Diabetes Association, we wanted to better understand how does an in-person model of offering the diabetes tune-up group compare to a telehealth delivered model. And would we see similar kinds of outcomes? And it was a genuine question. We also were interested to find out how many people would prefer to have a telehealth option versus an in-person option. And so in order to really evaluate that question, we allowed everyone in the study to choose which format they wanted to use. Very interesting, about 43% of our participants chose the telehealth option. They felt that that was really important, that lowered barriers to access. It made it easier to attend. Some were in retirement and weather and traffic and other kinds of barriers that would normally get in the way for attending something in person. For others, they were able to integrate that better with childcare responsibilities or work or commuting, and so that made it easier for them. And so we asked the same kind of question about outcomes in terms of diabetes distress and in terms of A1C, and then we asked it for each. We evaluated each of our formats, the in-person versus the telehealth. What we found was that everyone improved in terms of diabetes distress and that we saw a trend in the direction of lowered A1C. So we were thrilled to see both of those things. We also found that there was no difference, that there were the same improvements for both people in the in-person format and in the telehealth format, which gives us great confidence that this is the kind of intervention that can scale in a variety of different kinds of settings and be accessible not only to folks in a major metropolitan area, but also into non-metropolitan areas, rural areas, where people have access to technology, but don't necessarily have the time or the energy or the gas money to get to some commonplace in person.
No, I'm such a proponent of telehealth as like an access tool. So that is so good to hear, particularly in our rural areas where if you want to go to like see a physician, you're going to have to drive like an hour, you're going to have to take the day off work, all that stuff. So to hear that there's like statistical backing to these being significantly like effective programs in both sort of delivery methods, that's awesome to hear. Really exciting.
We were thrilled with the outcomes. When we do a study, we never know what our outcomes will be, but we had hoped that that would be the case, and in fact, that is what we found. So we were thrilled.
So I know this is anecdotal rather than like statistical, but do you have any feedback that you got from like participants of the diabetes tune-up group? Did you see changes in folks? Like, how did that look from where you're sitting?
So we've been very interested in people's lived experience of the diabetes tune-up group. Part of actually both studies, both our first study and our more recent American Diabetes Association funded study, we were very deliberate about capturing feedback from our participants. One, because we always want to improve, but also to see if people will vote with their feet. If they like it, they will attend. If it doesn't meet their needs, of course, they will find other things to meet those needs. Really been just delighted by the level of enthusiasm that we've received from our participants. We've done both quantitative data collection on levels of satisfaction with our diabetes tune-up group experience for our participants. And then we've also done qualitative focus groups where we have heard from our participants. Interestingly, one of the comments from our participants has been that they wanted more of the group. So they were, in fact, some were disappointed that it ended after 6 sessions. What we have found is that 6 sessions tends to be kind of just the right amount. It's that Goldilocks kind of effect of it's just right for most people. A longer series of sessions can feel like quite a commitment for most people. But people really enjoyed the group discussion. They thoroughly enjoyed the diabetes education. They were hungry for the diabetes education that was folded into the experience. Some came for the diabetes education, but discovered that they really needed the behavioral health components of that. And of course, people benefited from that, not only in terms of diabetes distress being lowered, but also in terms of depressive symptoms, which was not the primary target, but was a happy discovery, and self confidence in being able to manage diabetes. And so that's really important because one of the things we know is that if people don't have the intention to change behavior, if they don't feel confident in their ability to change their behavior, they won't change their behavior, right? It's human nature.
I asked Mary if she had any advice for providers in specific. This is what she had to share.
Two pieces for my fellow providers. One of those is that diabetes distress is real, and it is part of the air. It's in the air in our clinical encounters. So if as a provider you're feeling frustrated or you're feeling like your patient is struggling or is feeling a little stuck in their diabetes management journey, then it's good to be curious about diabetes distress. It's very easy to assess. There are measures such as the diabetes distress scale that people can use for free or incorporate into their clinical settings. But even just a conversation of what is your relationship with your diabetes right now? A simple question can really generate a lot of very important information for the provider to have a sense of where their patient is at. The second piece I would say is that there's good news about diabetes, right? People are living longer than any other time in the history of diabetes, and that we can address diabetes distress. Even though it comes with the territory, people don't have to stay distressed or burned out. And if we attend to that and we provide support, that's incredibly meaningful to our patients. And they will be so grateful and remain connected to care because they're receiving the support that they need. So there's really good news as providers for us to know that when we assess and when we address it, this doesn't have to be a barrier for our patients going forward.
And what does the future of the program look like?
We are very mindful and deliberate about creating interventions and then testing them thoroughly, and that's very important work because if we want to send something out into the world, we want to have confidence that that's going to be worthy of people's time and attention. But if the intervention doesn't actually ever get out into the world, then it just collects dust on bookshelves, and of course that's not the goal at all. So my hope is that if there are folks who are listening to this podcast, and for folks who read the articles that we've published about our experience, are interested, that. Healthcare systems and healthcare providers could use this intervention to help to support their patients with diabetes. And that what this takes is it uses technology, it leverages technology, but is fairly low tech, low cost from an investment perspective. So this is something that would require a bit of coordination in terms of getting groups of people together. But that's true for all kinds of groups, whether those are support groups or education groups, diabetes education classes, or something like this. And then it takes a bit of time to offer the groups, but again, this is something that we tend to do. We have folded into many different healthcare systems already, so we're leveraging those tools and those workflows, if you will. And then it's about learning the content, and that's the kind of thing that I'm happy to work with anyone that would be interested in using this intervention. If they would like to learn more about it, I'm happy to talk with them about that.
Thank you for joining us for this episode of A Virtual View, and a special thanks to our guest, Dr. Mary DeGroot. Talk to you again soon.
Thank you for listening to A Virtual View. You can find more information about today's episode in the show notes below. If you would like to support our podcast, please rate and review us on your favorite podcast platform. Do you have any questions or topics you'd like us to discuss? If so, contact us at info@umtrc.org or through the form found in the show notes. Also, we'd like to give a special thanks to our editor, Tristan Yoder. Finally, a special thanks to the Health Resources and Service Administration, also known as HRSA. Our podcast series, A Virtual View, is sponsored in part by HRSA's Telehealth Resource Center program, which is under HRSA's Office of the Administrator and the Office for the Advancement of Telehealth. The content and conclusions of this podcast are those of the UMTRC and should not be construed as the official policy of or the position of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Thanks for listening and have a great day.